So, before we begin, important content warning that this talk will touch on themes of suicide and intimate partner violence. So, the main question that I was asked when I first got here, and you learned that I worked in the emergency department, was, "What are you doing here?" And it's not that I don't think that you were happy to see me. It was more so I think that the linkages between emergency medicine and public policy aren't always clear. The short answer that I gave everyone was that long before I wanted to do medicine, I wanted to be a diplomat, which is true. But the long form answer is a little bit more involved, and it starts with a question back to you guys. What do you think is the purpose of an emergency department? And I think when we talk about the answer to this question, a lot of the intuitive answers are you're there to treat patients who come in with strokes, with seizures, with accidents. And that's true. But a lot more of the time, what we're treating are much more insidious causes of why someone might show up to the emergency department. There are two really illustrative examples of this over my time working. In 2021, I arrived to Nunavut, which is the most northern territory in Canada. And one of the first patients that I saw was a young woman who had come in because she had fractured both of her heel bones. And when you think about it, it's actually really hard to fracture your heels. It requires a significant, what we call axial load, like this. And when you asked her how this had happened, ultimately I learned that she had jumped out of a 3-story building trying to escape physical abuse from her partner. And when she left the emergency department that day, she would have nowhere to go except back to that same partner. As a doctor, it was then and many other instances during which I realized that to be a good physician meant not only treating the problem in front of me, not only casting those broken heels, giving her instructions on how to follow up, but thinking about how she got there in the first place. And realizing that the rates of intimate partner violence in northern Canada are about 10 times that in the south. Realizing that suicide rates are 5 to 25 times higher in northern and remote Canada than anywhere else in the country. And understanding that it was years of colonial policies that led to chronic underinvestment in the housing that people need, so that 80% of the housing stock in Nunavut is either overcrowded or otherwise unsuitable for people to live in, leading to these conditions where you have to go back to the same conditions that made you sick in the first place. The second incident that really opened my eyes when I was there was a couple of weeks later, after which we had patients who were coming in who were saying that their water tasted like gasoline. And I had started to notice this too. I didn't know what was going on, and for a couple of weeks, there wasn't an answer as to why it felt like this water was contaminated, but no one knew how. Ultimately, we realized that there was a gas pipe that had burst, and it was contaminating the entire water supply for the territory, so that everyone, in order to get access to drinkable water, would have to walk kilometers to the lakes and rivers that were freshwater. And if you think about it, obviously this isn't possible for a lot of people who either live far away, who have chronic conditions that prevent their mobility. And it was these conditions that made you think again, I can treat these patients for their headaches. I can do what I can for their stomach issues. But what we really need to think about are those underlying conditions. Why did this pipe burst? Was it because there were years and years upon which it took time for these pipes to get to the point where they were no longer suitable to actually carry drinking water to people? Only 14% of residents in Nunavut actually have access to piped drinking water every day. And this was directly because the Canadian government had underfunded renewing this infrastructure long past when it should have. So what do we do about this as physicians? And what is that linkage between emergency medicine and public policy? For me, it meant working to train medical students year after year to recognize the root causes of these issues so that they could advocate, go to Parliament, talk to people who could actually make changes, write opinion pieces in the newspaper, and sound the alarm for all of these upstream issues that we were seeing. I remember the first protest that I went to was in 2012, and it was because of cuts to the interim federal health program in Canada, which funded basic health care and emergency care for asylum seekers and refugees in Canada. Our government at that time had decided the program wasn't worth it, so this entire generation of people who were newly arriving to the country would no longer have access to health care when they needed it. And that was the first time that I joined and looked up to physicians who stood out and who weren't afraid to use their platform and their power and their voice to advocate for the patients that they were seeing in the emergency department. in 2015, after years and years of sustained pressure by my colleagues, as well as by other members of the public and NGOs, finally these cuts were reversed. And it was at that moment that I understood how powerful and influential public policy could single-handedly be in reversing the course of access to healthcare and in improving equity for all. So while I'm not exactly sure where my journey goes from here, I do know that public policy is the starting place by which you can single-handedly improve on a more effective and immediate basis the conditions that people live in. And that's the impact that I hope to make in the future.